Well, are you as confused as I am as to why in the last 2 to 3 years topographically driven lasers were so effective, and now we're told that wavefront refraction driven lasers are the way to go? Well, vector planning for me is I see the way to integrate the best numbers that we get from both these excellent modes of measurement. I acknowledge my financial interest in the ASSORT Planning and Outcomes Analysis program. You know, there's two fundamental ways of measuring astigmatism. That's the difference. One's the corneal shape by topography, and secondly is the refractive values, the optical correction by refraction. So on the corneal shape side of things, we have keratometry, which gives us a very good overall measure of astigmatism. Keratoscopy gives us a more sophisticated way of looking at it. And then we get a computer to help us to look at the keratoscopy and gives us the computer-assisted video keratoscopy that we know is computed as corneal topography. On the refraction side of things, there's the spectacles, the manifest refraction, which is our most common and important mode that also includes the perceptual level of astigmatism measurement. Then 20 years ago, we went through autorefractors. That gives us an automated view of the optical components of astigmatism and refraction, and now we have the wavefront refraction, which gives us a very sophisticated map of the optical components of the refraction. But when you look at these two sides, they are quite different. And on one side we have the corneal shape, and the other side we are talking totally refractive, totally refractive. So how does this limit our treatment? Well, if we treat purely by corneal topography, then we only really have it in a customised sense. And Dr. Herzig gave us a good example of that, where we can't really systematise it. We have to individualise it for each patient. In this way, he also alluded to the fact that we do actually get inconsistent and predictable refractive results as a result of this. Manifest refraction, well, its advantage is it includes the optical and the perceptual level of astigmatism, but it leaves avoidable corneal astigmatism remaining, and as a result, we can end up with increased aberrations as a result of this astigmatism. Autorefractor, well, once again, only optical components. And as you all know, if we try to prescribe spectacles off the autorefractor, we get a very high level of patient dissatisfaction, so we don't pursue that. The wavefront refraction, well, it really corrects all the aberrations within the eye on the surface. And so by doing that, all these optical aberrations are reproduced on the corneal surface to neutralise them. And when it looks at these aberrations within the eye, it actually can sometimes get conflicts between hyperopic errors within the system that might be adjacent, or hyperopic and myopic errors, that in the end we can end up sometimes with conflicting priorities between the adjacent regions and asking for subtracting and adding tissue in the same region. I mentioned the perceptual side of things. Wavefront refraction does not give us the perceptual view of astigmatism. So just like autorefractors, it actually excludes the non-optical components of perceptual astigmatism. And the other aspect of it is that it doesn't actually address the underlying topography that is actually going to change. So that because of these differences that exist between refractive and corneal values, we leave avoidable corneal astigmatism remaining. As a result, I would see that wavefront refraction really has fundamental obstacles to overcome before it's being considered as the sole treatment parameter. If you introduce vector planning, it enables us to be able to bring topography and refraction, any one of those refractive modalities, into the planning process. So if we look at a cornea with irregular astigmatism, you have a superior topographical value, an inferior topographical value, so we have some degree of asymmetry and also non-orthogonal. So that addresses the irregularity. We have the spherical component we need to correct, from the change from the pre-op to the targeted spherical equivalent of 0, or whatever we choose, and that goes into the treatment mode. And then we have the cylindrical component, which when combined with the topographical component provides us with a value of a treatment in the superior component, the superior treatment or the superior TIA, which is translated into the treatment. And we have the inferior component, which, combining the refractive and topographic values, gives us a cylindrical value which also goes into the treatment. So in this way we have an asymmetrical, spherocylindrical laser treatment that is customised individually for each patient as their treatment arises. In summary, there are two fundamentally different ways of measuring astigmatism, and these are likely to prevail for the foreseeable future. Vector planning enables both the topography and the refraction values to be linked in the treatment. Integrating both these modalities actually customises the treatment and overall leaves less corneal astigmatism remaining, and in this way reduces aberrations. And vector planning in this way addresses corneal irregularities systematically. Ever since the days of AK and PRK, it's never really made any sense to me to treat exclusively by topography or refraction. And by using vector planning, I think the best modes of measurements can be considered and combined. So it isn't really a question of topography or refraction. Vector planning enables you to treat by topography and refraction. Thank you.
Thank you, Noel. Any comments from the panel? Noel, do you think that people will eventually sort of have a signature, like some doctors will use a 50-50 contribution of topography and refraction, and other doctors will have more success in their hands with 70-30, or?
You know, I think everyone can develop their own paradigm. It's really a surgical decision about whether you go all the way to refraction, all the way to topography, or somewhere in between. You know, you can work out an optimised plan based on ideas of which might be more favourable and less favourable, but as long as you're working in the area of what I call the maximal astigmatism treatment, ending up with the minimum remaining astigmatism, you're in safe territory.